Hello, this is Lauren Trudeau, and this is the pathophysiology of breast hypertrophy. Starting with the history of present illness, the patient in room 3213 is a 28-year-old African-American female. She began experiencing pain in her neck, shoulders, and back, so she came to Chesapeake Regional on October 2nd and underwent a bilateral breast reduction. The patient was admitted to the floor after the surgery, and she has a history of obesity, GERD, and leukemia. She's utilizing things such as bilateral Jackson-Pratt drains, ABD pads on her incision, and a compression bra. Pain management and anti-embolism precautions are being done, and she is receiving 30 milligrams of enoxaparin and 10 milligrams of oxycodone. So moving on to the admitting diagnosis, which was breast hypertrophy. This is commonly seen in women and can be due to excess glandular tissue development, weight gain, or increasing fat depositions in the breast tissue. Tissues grow by an increase in the number or size of cells. Normally, tissues will reach a certain level of cells and stay at that level, whereas other tissues, such as in the breast, are regenerative, meaning that they have the ability to continue producing cells. This continual cell division causes organs to increase in size, which is known as hyperplasia. Glandular tissues in the breast contain O-estrogen and progesterone receptors. O-estrogen have an effect on epithelial cell proliferation and bind to nuclear receptors ER alpha and ER beta. The most intense mitotic activity of cells in the whole breast gland is during the luteal phase, leading to the largest dimensions of the mammary gland. The tissue is sensitive to these hormones as they drop during the menstrual cycle. This sensitivity leads to a buildup of fat cells, which are then sent into the connective tissue of the breast, ultimately causing the increasing breast size. Moving on to comorbidities that the patient had, such as obesity, GERD, and leukemia. So diving into obesity first, obesity is a state of chronic inflammation of adipose tissue along with malnutrition due to excess nutrients. As a result of this, the hormonal and immune system become defective. In contrast to non-obese people who secrete anti-inflammatory adipokines, an obese individual will secrete pro-inflammatory cytokines from the adipose tissue. These include tumor necrosis factors, interleukin-6, resistin, cisplatin, leptin, angiotensin II, and plasminogen activator inhibitor 1. Obesity is linked to abnormally high expression of the enzyme aromatase in the breast due to the increase of pro-inflammatory factors. This is the converting factor of androgens into estrogen. High levels of estrogen encourage the proliferation of breast cells. Leukemia involves the rapid growth of abnormal and immature blood cells, leading to cancer inside the blood. Most of the body's blood is created in bone marrow. This is also where the uncontrolled growth occurs. This cancer occurs due to the malignant transformation of pluripotent hematopoietic stem cells. These immature, poorly differentiated abnormal blasts undergo clonal expansion and proliferation. They then replace and interfere with the development and function of normal blood cells. Risk factors for developing breast hypertrophy include hormonal changes. An example of this can be pregnancy, and I included this because it was more specific to the patient. She does have a toddler at home and has gone through the hormonal changes of pregnancy. obesity, genetics, and the fact that she is a female. Physical assessment findings. The patient was alert and oriented ×4. She was very unmotivated to move and wanted everything done for her. She was calm and respectful. Her S1 and S2 heart sounds were heard, and she had a regular rate and rhythm. Her bilateral radial and pedal pulses were at a +2. They were a little weak, but her capillary refills were less than 3 seconds, and she had no edema. Her lung sounds were clear, no accessory work at breathing, and her O2 stat was 100. Her bowel sounds were active, and her abdomen was soft and undistended, although it was sore when I was listening for her bowel sounds. She was able to get up and use the bathroom, and her last bowel movement was on October 2nd. She had purposeful movements in all of her extremities, although it was painful for her to twist. Therefore, she needed help wiping when she went to the bathroom, and she was just moving slow due to the pain involved with that. She was able to ambulate, and she used a walker, and she had a slow and steady gait, and her IV was patent and dry. She had no diagnostics documented, so I just wanted to include that. And the only abnormal lab value was that she had a slightly high CO2 level of her blood. This could be caused by bed rest after surgery, decreasing anything about with like respiratory rate, just slowing down her breathing and work of breathing. This just means that the patient is not getting rid of enough CO2 when she is breathing. Moving on to vital signs. These, again, were all pretty normal. Her blood pressure was 120/93, temperature 98.3, heart rate 85, respiratory rate 18, and her oxygen 100. Medications that she was receiving was enoxaparin, 30 milligrams 2 times daily for deep vein thrombosis prevention. And she was also prescribed oxycodone, 10 milligrams as needed for pain. The top nursing diagnosis that I chose for this patient is actual acute pain related to the inflammatory process. Cues that led me to this is that the patient has undergone major surgery, has rated her pain a 7 to 8, and is having difficulty moving, and is utilizing things such as the Jackson Pratt trains. Goal number 1 is that the patient will perform activities of daily living easier, and to reach this goal, the nurse will teach the patient about pharmacological and non-pharmacological pain interventions, as well as the importance of walking, ambulating, getting up, and moving your body. The second goal for this patient is that she will report that the pain management regimen is achieving comfort. To meet this goal, the nurse will advocate for and manage acute pain using a multimodal opioid-sparing approach. And the nurse will also perform nursing care at peak effects of pain medications. Treatment plan for this patient includes managing her pain with the opioid that was prescribed as needed, monitoring and assessing her incisions, dressings, and drainage from her drains. And it was very important to ambulate this patient as soon as possible, and she was also using the SCD machines to prevent deep vein thrombosis as well. Financial considerations for this patient is considering that recovery typically ranges from 3 to 6 months. The patient will most likely be out of work for some time. This can mean a decrease in income, which can influence the patient's ability to do lots of things after surgery, such as attend follow-up visits, and it can even affect things such as childcare for her. Post-shift evaluations is that the patient is Still in the hospitalization phase of her admission, halfway through the shift, the patient got up and walked for the first time in 3 days after refusing to move, and the patient is still experiencing pain rating of 7 to 8, and she's receiving medications for that. There did seem to be a positive shift in motivation towards the end of the shift. These are my references. Thank you for watching.